All right, everybody. So, welcome to another Grand Rounds. Today is quite a special one. One, it is Heart Month, given that it's February. And secondly, we have a wonderful speaker, a guest speaker, who I'm really lucky to call a dear friend, someone who I've admired for a really long time and have gotten to know over the past couple of years. This is Dr. Nasreen Ibrahim. She is a heart failure and transplant cardiologist out of Brigham and Women's in Boston, Massachusetts. She is a fierce advocate for health equity in cardiology and medicine, and has also created a nonprofit which improves access to heart transplant for all patients. So like I said, we're going to try something a little bit different today. And Nasreen is going to get into her talk after this, but I'm going to ask Nasreen a couple of questions first. So Nasreen, welcome. I know you're on inpatient service, so I'm really happy that you were able to make the time to join us.
Of course. Thanks for having me. This is exciting.
Yeah. So what made you choose a career in heart failure?
So the crazy thing is I went into medicine thinking I was going to be an oncologist. And so that's why I picked internal medicine. And I was like hell bent on going into oncology. My dad's an oncologist, but then I absolutely hated my oncology rotation the first week I did it. And then I ended up loving heart failure. And the funny thing is, everybody says I picked the oncology of cardiology, essentially because we take care of super sick patients. And that's what I loved. Like, I love taking care of super, super sick patients. I love like the long-term relationship aspect with the patients, but also having this opportunity to play a small role in transplant. So, giving patients a second chance at life. I don't think that we do that. I think there's something bigger, a higher power that is responsible for life and death, but we get to play a small role. And of course, not everybody gets to have a heart transplant or get an LVAD, but you also, when you get to end stage heart failure patients, you help patients live out whatever life they have left with dignity and comfort and how they want to live what remains of their life. And so I see the super sick heart failure patients. So I see patients that are now stage D and we're thinking about transplant and VAD. And so I think it's amazing work. It's tough. The patients are sick, but it's really gratifying work that we do.
Yeah, amazing, amazing. Yeah, I don't think I ever could have gone into heart failure specifically, but happy to have people like you that are able to do the job so well. So, secondly, since you started your career as a transplant as a transplant cardiologist, what has been the biggest challenge that you think you've had to face when it comes to access to advanced heart failure and transplant services for your patients?
So I would say it's financial, even not necessarily when you get to VAD and transplant, but even with bread and butter heart failure. So now we have like two classes of guideline directed medical therapies that are amazing. We, talk about them, we tweet about them. We know they reduce mortality better than the old school drugs. So I'm talking about ARNIs, so sacubitril valsartan. I'm talking about the SGLT2 inhibitors. But when you're talking about access, again, the copays are sometimes unaffordable to patients. And I know the companies have coupons, they have patient assistance programs, but even then, not everybody is able to get through those hoops to get access to those medications. And then specifically to answer your questions about advanced therapies, people are always like, well, if you're sick, we're going to transplant you. But no, you go through this psychosocial evaluation and finances come into play. Your psychosocial support, your psychosocial evaluation comes into play. And what I mean by financial is even if you do have insurance, the copays for some of the post-transplant medications are high. But also a financial decision has to be made if, say, I need a heart transplant and my spouse has to take time off work. And then now we have young kids at home. Who's going to take care of the kids? We have to put them in daycare. So that becomes a financial burden. But also, lots of transplant centers expect patients to live within a certain mile radius post transplant. And so now I'm asking somebody who might live way up in Maine to now move to Boston for 3 months post transplant because we want them close in case something happens. So not many people can afford housing in Boston, in addition to whatever housing they're paying for at home. So lots of financial considerations come into play when we're deciding who gets to get a transplant or an LVAD and who doesn't.
Yeah, and I think that's something that a lot of us, especially when we come up in training, we don't really think about, right? And so this is like a nice segue into the last question. And you've started your nonprofit organization really to deal with, a lot of these inequities. And you're doing such amazing work so far, and I'm so proud of you. And I know you're going to get into a little bit about your nonprofit when you do your talk, but what do you think motivated you to start your nonprofit to begin with?
It's, to be honest, it's the stories that have traumatized me. So since I was a fellow all the way through my early years as an attending, it's the stories that have haunted me. To think that, like, in one of the wealthiest countries in the world, we're essentially letting people die based on a few $1,000s. Like I always say, in America, we let people die based on the cost of a Louis Vuitton bag. And so, yes, I like nice things. Everybody likes nice things, but it's really the patient stories, and it's all kinds of patients. People are say, just racial and ethnic minority populations, but it's not. There's low income rural Americans that live in mobile homes, and we're 100% not going to transplant you if you're going to go home to a mobile home, or we're not going to give you an LVAD if you're going to go to a mobile home. So again, finances affect everyone. And it's one particular story of a patient that I saw when I was a fellow that came in Montana Medicaid. So Montana Medicaid does not cover heart transplant. He was crashing and burning. We put him on ECMO, and we were trying to figure out any which way that we could to get him an LVAD or a transplant. So lots of issues in just one person. So he had Medicaid, Montana Medicaid, which does not cover heart transplant in adults. He lived in a mobile home, so there was no way we were going to put an LVAD in him without like stable source of electricity. And the third thing was that he had some mental health issues, and so was estranged from his family. And at the time, I was in my 30s, and we were the same age, and all those things, even though the hospital said, okay, we'll do the operation for free, but once he leaves the doors of the hospital, he doesn't have the psychosocial support system. He lives in a mobile home. So there were so many barriers in just one patient, and we ultimately ended up letting a patient my age at the time in his early 30s die. And so it was his story that has stuck with me throughout. And these are the systems that we're trying to dismantle in transplant selection to make it more equitable. And I think even the more horrific thing about this whole story is he was a US veteran that was dishonorably discharged from the military for marijuana in his urine. And so he didn't have access to VA healthcare systems, which would have helped in his case. But very sad story, but not the only story. There's been many, many along the way of $5,000 making a difference in whether somebody's going to get listed for a transplant or not.
That's incredible. And thank you for sharing that. And again, so happy to have you. And now I'm going to share my screen so we can get your talk started.
So thank you for having me. I'm going to talk a little bit about just the background of why we do the work we do, and a little bit about the nonprofit, and also just some data when it comes to disparities in advanced heart failure. Next slide, and then next slide. I don't have any disclosures relevant to this talk other than I am the founder and executive director of the Equity in Heart Transplant Project. So three major topics that I just want to touch on today is we need to look at heart failure as a public health emergency. I'm going to talk about inequities in access to heart transplants specifically, but they're not unique just to hearts. There are also issues with other organ transplants as well that are similar to what we see with heart transplantation. And then I hate talking and publishing and writing just about the problem. So this is going to be more solution focused. And so we're going to talk about strategies to improve access to heart transplantation in all patients. So just so you're aware and everybody's aware, so the global burden of heart failure is massive. And the worst is, as we see here in the red, is in North America. But I think there's an underestimation of heart failure globally. And I know that because I've tried to do projects in other countries. And so I've been asked, specifically in Egypt, my mom that's her country of origin. I've been asked to help the government start a heart transplant program there, but even trying to understand what the numbers are and what the need would be when it comes to advanced heart failure therapies there aren't really great databases where they collect information on who has heart failure, what the burden is, what the prevalence is. So I do think there's an underestimation of how much heart failure affects the populations globally. All right, next. So you've seen these numbers, I'm sure, before. An estimated 6 million Americans have heart failure, and there's 1 million new cases annually. And it's an expensive ordeal. So from between 2012 to 2030, there's going to be a 127% increase in how much we spend on heart failure. So that's about $70 billion in 2030. This number hasn't changed. So when a person is diagnosed with heart failure, they have a 50% chance that they will not make it to 5 years. And as the population continues to live longer, we're going to see just a much higher burden of heart failure throughout the country. Next. So I like to actually share this trajectory with a lot of patients. So when patients are diagnosed with heart failure, this period of stability can last anywhere from just a couple years all the way to decades. But it's when you start seeing these decompensations. So the patients are coming in to the emergency department frequently for acute decompensated heart failure, or the patients are being seen in clinic to get IV diuretics. So you see this progression where they're coming in no matter what you're doing to try to keep them out of the hospital. You're talking to them about fluid restriction, moderate sodium intake, you're adjusting their diuretics, but for whatever reason, they keep coming back. And I always say it's just the heart is getting sicker. And it's at this point that you have to think about, okay, what's the next step? Are we going to talk about heart failure or heart transplant, LVADs, or if the patient doesn't qualify for either one of them, are we going to think about palliative inotropes or the involvement of the palliative care and the hospice teams? Next. So there's large disparities in who is hospitalized for heart failure. And as you can see here, the yellow is Black women and men. So heart failure hospitalization rates are the highest for Black and Hispanic patients. And for Black patients in particular, their heart failure hospitalization rates is 2.5 times higher than for white patients. Next slide. And when we talk about heart failure related cardiovascular death, so the figure on the left is for young adults, so 35 to 64. The highest mortality when it comes to heart failure is in Black men, followed by Black women. On the right is older adults, so 65 to 84. Men have the highest mortality compared to women. And the age group that we're more concerned about, we should be concerned about all of them, but really from 35 to 64, because this is the age group where these patients should be considered for advanced therapies like LVADs and transplants that we know prolong life. Next slide, too. And even when you look at children, so these are teenagers aged 15 to 44, Black individuals have the highest heart failure related cardiovascular death. And I always like to show this slide because when I was first putting this slide together, I wrote Black women and men, but we're talking about children, even teenagers age 15, you can see there's a huge disparity in heart failure related mortality in this race. Next. And so who gets transplanted? On the left, you can see this hasn't changed for decades. On the left is who we list for transplant. So we list more white patients for transplant compared to Black or Hispanic patients. And of course, on the right, this is data we published in 2021, I believe, with a group at Yale. So on the right, you see who we transplant. So we list more white patients, we transplant more white patients. And of course, in the United States, the majority of population is white. However, I just showed you data showing that Black patients especially have much higher morbidity and mortality. They present earlier, they present sicker, and also have poorer access to everything from guideline-directed medical therapies, even CRT and defibrillators, all the way to transplant. Next slide. So how do we decide who gets transplanted? So this was in a magazine in 1962. It was Life magazine. And this is a committee, they called themselves the God Squad. And this is where the origins of transplant ethics and policy started. And this was a group of 7 people. They were anonymous. There was a minister, a lawyer, a businessman, a homemaker, a labor leader, and 2 physicians. And each month they would get dozens of charts and they would look through them. And these are patients that had end stage kidney failure, and they would decide which of these patients would go on to dialysis. So they would look through these charts and they would pick 2 patients each month that would go on to dialysis, and the rest of the patients would be left to succumb to their end-stage kidney disease. And so, of course, things have changed about how we select patients for transplant, but there's still inherent issues with how we make these decisions, filled with lots of subjective reasons to deny patients from transplant, and lots of bias. Next slide. So I like to think of transplant selection in 3 buckets. So the first one is the easiest, so medical. So does the patient, is the transplant medically necessary? So we know in heart transplants, we have these thresholds. We get cardiopulmonary exercise testing. We look and see what the peak VO2 is. We look and see what their blood pressure response is. We look and see, you know, they've been hypotensive, they've needed dobutamine every time they've been admitted. So that's usually the easiest part, is medically, does the patient need a heart transplant, or is the patient too sick? And at this point, we don't think they're going to survive the operation, or they're not going to survive at least 1 year post-transplant. So that's the easiest part. The second 2 parts, so financial and psychosocial. Financial is not just do they have insurance, but do they have adequate insurance? Does their insurance cover heart transplant? Does their insurance, are their co-payments reasonable post-transplant? One example where co-payments can be really outrageous is when it comes to hepatitis C transplants. As you know, we've been doing hepatitis C heart transplants for several years now, and the outcomes are excellent. But the problem is, once you put a hep C donor heart in someone, you have to give them these super expensive antiviral medications for a few months after transplant, and not all insurance plans cover the cost of these medications that well. So one patient, for example, their monthly antiviral medication was going to cost, the monthly cost was $5,000. And so for that patient, we weren't going to accept hepatitis C hearts, because we didn't want to put a hep C heart in and then the patient not able to take the antiviral medication for the few months post-transplant. The other part too is there's something called a wallet biopsy that's done. So if you are the CEO of a Fortune 500 company, we're not going to ask how much money you have or to look in your bank accounts. But if you are just a regular person, like most of us, there's a wallet biopsy. So we want to make sure that patients have at least $10,000, because that's the estimate for the cost of the out-of-pocket cost for 1 year post-transplant. And I keep saying 1 year, it's because that's what we're graded on. So what your 1 year post-transplant survival is what we get rated on. And so that's what we most of the time care for. Can we at least get the patient through 1 year? And then, of course, the psychosocial evaluation. Do you have a caregiver? Do you have somebody to watch your kids if you're going to be transplanted? And then, of course, things like substance use and weight. That's one of the things that we take into place is BMI, even though we know body mass index is not a great measure of health. That's used to also eliminate patients from transplant. Next. And so when you sit around these meetings and you're deciding whether or not somebody's a candidate, these are closed door meetings. And there's all kinds of subspecialists in there. There are surgeons, there's cardiologists, there's social workers, there's financial people, there's psychiatrists, and you're all presenting this patient from head to toe. It's important to challenge this groupthink. And so I think the best ways that I've seen leaders of transplant centers do it is not to say what their opinion is in the beginning. Because if you can imagine, if the chair of transplant surgery says, no way, I don't think we should transplant this woman or this man, you know, the likelihood of everybody else in the room disagreeing is going to be less. So there's ways to challenge this groupthink and start asking the opinions of people that may have less authority in terms of the final decision making and whether or not a patient gets transplanted. And so that's important to think about these things, not just who's in the room, but how the patients are presented in the room, so that it's in a very fair and objective way, but also giving a chance for everybody to feel safe and comfortable giving their opinion when these decisions are made. Next. So this is just the wallet biopsy that I had mentioned. So this is from CNN published this article in 2018. And the reason they published it is because this patient got a letter in the mail saying she was not going to be listed for transplant at this certain center because she didn't have $10,000 and they recommend fundraising. And of course, it went viral on social media. And then you had all these policymakers and elected officials saying, this is horrible. We're letting people die based on $10,000. But of course, people get excited about things and then nothing happens. And of course, nothing happened. Next. And so before we jump into talking about how we address these disparities, we use these words interchangeably, but they mean very different things. And so equality, I just wanted to go over the definitions really quickly, which you probably already know. Equality means giving everybody the same thing, so the same pair of shoes. Diversity is everyone getting a different type of shoe, but really equity is what we're focused on here, is giving everybody the shoe that fits. So whatever they need to, walk comfortably is what we provide people. Next slide. And so, when we talk about disparities in access, I always like to say, well, what are we doing in Boston? Because you have to talk about what's happening at home before we can say what's happening in other centers. And so this was a Boston Globe Spotlight series that was published a few years ago, and it was a 7-part series, and they looked at racism, disparities, inequities in different sectors in the city of Boston. So they looked at housing, they looked at sports, and then one of the really most shocking ones was the one about healthcare. And so they talked a lot about how we have these world-class institutions in Boston. We have Mass General, we have Brigham and Women's, we have Boston Children's, and people fly from all over the world to get this world-class care. But Black Bostonians really don't come to these hospitals. And it's difficult by public transportation to get here. We know there's other issues when it comes to parking and just traffic in the city. And so this concern was raised about us having these amazing hospitals, but they're not catering to the people that have some of the worst health outcomes in our city. Next slide. So when you look at the numbers in Boston and who we transplant, it's really 7% of the hearts that have ever, this is just the last 5 years, but 7% of the hearts that have ever been transplanted in the city of Boston have been done in Black patients. It's a similar percentage in Hispanic patients, or Latinx patients, and that's really across all the adult heart transplant centers. So that's Brigham and Women's, Mass General, and Tufts as well. Next. So to dismantle these disparities, we need structural interventions because they're the reason for this. Next slide. And so we know that health disparities are a symptom of a much broader social and economic inequities. And I won't go through all of these, but I always use the example, which was an eye-opening example to me, that we're sitting in our fancy offices and I'm telling the patient, walking is good, exercise is good. You just, go outside and walk 15 minutes one direction, 15 minutes back. But then the patient said, well, doc, we don't have sidewalks in my neighborhood. And so that's how structural inequities, if a neighborhood doesn't have sidewalks or doesn't have sidewalks that are safe for people to walk on, that directly impacts their ability to exercise and then ultimately their health. Next slide. And so policies at every level influence equity and organ allocation. Next slide. So just to run through really quickly scenarios. So this scenario is a 45-year-old woman who is a single mother. She's a school superintendent. She has good insurance. But now we're saying who is going to be the caregiver. She doesn't have a family where she lives. She doesn't have a partner. And so church members have volunteered to be her caregivers. Does your transplant center say, okay, well, we'll take these as her caregivers and we'll accept her for transplant based on church members saying they volunteer to be her caregivers? Next slide. Scenario 2, we published this last year. So this is when it comes to transplanting undocumented immigrants. And so the data shows across all organs that we take organs from undocumented people when they die in the US, but we don't give them organs depending on what state you're in. So if you live in California, California Medicaid provides undocumented people with insurance, so they're able to get transplanted, but not if you live in another state where they don't have insurance. So again, how ethical is it that we are taking organs from undocumented people, but we are not giving them organs? Next. Another scenario is how we talk about patients. So this is a real scenario, a patient that I had worked my butt off to get them to understand that they were going to die without a transplant. At the selection meeting, the social worker says, well, they're dragging their feet. If this patient doesn't need a heart transplant, they shouldn't waste our time. And I didn't understand because I had maybe 6 or 7 appointments until we got to the patient agreeing to get listed. And when I called the patient, I said, you know, what's going on? I thought you said you were okay with moving forward with the transplant. He said, well, doc, when I went to the dentist, they quoted me $6,500 to get my dental work done. And I'm ashamed and I'm embarrassed. I don't have $6,500 to get the dental work that's necessary to get me listed. Next. And so I mentioned this briefly, that state Medicaid, not all states cover heart transplant. So if you are young and low income in Montana, Nevada, or Georgia, your Medicaid does not cover heart transplant in adults. It covers other organs, but not heart transplant in adults. Next. So potential solutions, again, less restrictive center policies. So what does your center do? If we're in Boston saying you have to live here for 6 months, where does the 6 months come from? Why don't we try doing 1 month, or why don't we try doing 3 months? So sometimes we make these rules that are not based on data that end up making transplant less accessible. Things like modifiable risk factors. And what I mean by that is smoking. We can talk about smoking cessation, weight loss. Some centers have a BMI cutoff of 35 and other centers it's 40. So what are we actually doing to help patients become better candidates? And do we have enough resources, and are we willing to invest in patients rather than say, well, you're not a candidate, go lose 50 pounds, even though you can barely climb 1 flight of stairs, because, you know, it's such a, it's such a scarce resource that there's always other people that we can list. And then self-reflection, does your transplant, who you transplant, the demographics of who gets listed and transplanted at your institution, does that match the city demographics? And I would say for Boston, absolutely not. 25% of the people that live in Boston are Black, and we only transplant 7% Black patients. Next. So what we're doing at the Brigham, when I got here, we got a grant to look at the mechanisms of disparities in access to transplant and VADs, specifically at Brigham and Women's. And this is more so looking at the reasons patients were turned down. Next. And what we're also doing is we've partnered with the Boston Public Health Commission to move our clinics to where patients are, because a lot of it has to do it starts way upstream. So even before patients finally end up at the Brigham and we're presenting them at transplant selection, who even gets sent to the Brigham or to Mass General or to Tufts? There's a lot of patients that we're missing that never even get sent to us for consideration of transplant. Next. So next, I just want to say that grassroots level advocacy works. And this is an example from kidney transplant. And so this is a picture in 2013 outside of Northwestern. And there was an undocumented young child, 5 years old, that needed a kidney transplant. So she's undocumented. Her mother is undocumented. And her mother was willing to donate her own kidney to the child, but this was against the laws of Medicaid or the healthcare systems in Illinois. And so these people took to the streets. It was religious leaders, patients, clinicians, there was physicians, nurses, all kinds of people that work in the hospital, social workers. So they were demonstrating for 1 year outside of all major Chicago hospitals. This just happens to be outside of Northwestern. So after 1 year of demonstrations and hunger strikes and really disrupting what was going on when it came to this young child and their mother, the state of Illinois became the first state in the US to allow undocumented people to get kidney transplants. And so this all started because of one person, one story, one child, and a group of very motivated people to change the laws in Illinois. Next. And so why do we do the work that we do? Because poverty should not be a death sentence. Next. And you can fly through these. So the Equity and Heart Transplant Project is a 501c3 public charity. Next slide. I founded this in June of 2022. Next slide. Next slide. And we started accepting applications for assistance in September of 2022. And since then, we have helped 31 people in the United States get listed for a heart transplant. Next, we can look at the demographics. The average age is 47. So these are young people. More men than women, which is not unusual. So 27 men, 4 women. And I'm saying it's not unusual because, again, when we look at disparities, there are sex disparities and more men than women are listed for heart transplant. And it's really shocking. 37% of them have an annual household income less than 40,000. 43% have an annual household income less than 20,000. And we've covered everything from housing, medication co-payments. Last year, we bought a one-year insurance plan for an engineer that had been working his whole life, but for the last 5 years was incredibly ill from his heart failure, lost his insurance. His wife made a little too much for Medicaid in Florida. And so we bought him an insurance plan for 1 year because we expect him after transplant to get better. And so we are a grassroots effort. This is all a volunteer-based organization. Most of the way that we raise money is from individual donors, but also partnering with corporations. Next. And then it doesn't end here. So we want this work not just to change people's lives in terms of helping the patient get access to a heart transplant, and obviously it affects them and helps them and their family and their community, but also how we can advocate so that the policies that make heart transplant not accessible are changed. And so this was, again, somebody from HRSA, which is the organization that's really trying to dismantle how we currently allocate organs. It's a government organization that's responsible for this new, potentially modernizing the organ allocation system. They reached out to us on LinkedIn, and we've been meeting with them to give them our what we see boots on the ground. And it's crazy that these people are the ones in government making the decisions, but they have no idea what actually happens when we're deciding who gets a transplant and who doesn't. And it's funny, every meeting they're so shocked when I'm like, yes, we'll let people die if they can't afford housing or to pay their rent. Next slide. And then this is just local advocacy we've done at the Massachusetts State House related to work we've done in our nonprofit. Next slide. And so people always ask me, like, why do you do what you do and what can I do? I just say, find something you're mad about and fix it. Next slide. And lessons learned throughout this process is people prefer to pay for something than cut you a check. So we throw events. People like to come to parties and concerts. So that's how you raise money. I say, shoot your shot every time. You never know who's going to respond. One of our advisors is the former CEO of United Airlines, Oscar Munoz. He got transplanted in 2016. And so he's been a huge advisor of ours and a huge supporter. And then the last lesson is that there are good people in this world. You just have to find them. Next. And then next, you could just, so thank you. I know I spoke a little over time, but I just wanted to share everything with you all. Thank you for this opportunity. It's been an amazing journey, and thank you, Umbreen, for having me.